record this lecture. Now the lecture is being recorded. So once again, thank you guys for joining me in this evening. This is gonna be as fast as the last time, I think. And we're gonna talk about this, two cases actually. It's gonna be a third one, but the third one is only to set as an example. I wanna talk about this case here. Only to remember a few things. I'll have the chat window open, so anything you wanna talk about or comment or any questions that you might have, please remember to use the chat, because the chat is gonna be open all the time here. And also, as usual, at the end of the lecture, I'm gonna leave my email and my social media account as well. If you don't feel comfortable using the email anymore, I know it's more of a older people like me, we like to use the email. But if you feel more comfortable, please, you can reach me also through my social media like Instagram or Facebook. So it is always a big honor. And you can see by the two pictures here that I got a haircut. And to be honest, I prefer the haircut and not as big as this in this picture. Okay, so today is the 5th time we're having this discussion. There's 3 more. It is gonna be awesome. Next one, I know I've been telling you guys this. Next one is gonna be great. Next one is gonna be great. But next one is really gonna be great. It's one of my favorite cases we're gonna talk about next week. But today is also a very nice case. And this is the case. This is the case because it's a case that I did along with a friend. Actually, it was not my patient. It was Fernando's patient. And Fernando is a good friend, and he's a teacher of ceramics, of indirect restorations. But the case here, and why this case is so challenging, it is because it was not possible that the patient came to Fernando asking to do ceramics, but in the space of only 1 week. And why was that? Because her son was gonna graduate by the end of the week. So Fernando said to her, man, it is impossible to do that in a week. She asked Fernando to do something faster. The only way we can do something faster, it is doing composites. And that was the deal. How can we, let's say, fight? How can we overcome in a better way the color? Because it's like a C2, maybe C3. And we also have some, failing composites and this diastema. So we have signs of age. And how can we do that faster in less than 1 week with composites? So this is the challenge. And there's a little hidden challenge that I want to show today, because one of the topics I want to talk about today, it is getting control of the operatory field, how to control tissues. So I will start with this one and I'll move on to some other. So this one is a very easy one to get control of the operatory field, but there's a hidden thing I want to show in this case. Next case, I want to show how hard it was and how necessary it was to get control of the operatory field. So without any further delay, we can take a look here, and we can see here with my cursor, the little arrow, we can see that there is a failing composite, not so good. But other than that, all of those teeth, they're sound, they're healthy, they're good. And this is one of the things. This is one of the things we want to change as well. Not only the shape, we also want to change the color of the tooth. Have a more lighten up tooth. But there's no time to do what? And we talked about that on the second lecture and case discussion that we had about bleaching. I don't have time to do bleaching, because even if I combine techniques, there's no time. There's going to be too much oxygen, and we all know oxygen inhibits what? Curing of the composite. So there's no time to do bleaching as well. We need to hide and change the color of the tooth with composites only in this given week, which is too little. I know it is not ideal, but sometimes in the real world, that's what happens. So we took a closer look, and usually we do this kind of isolation with the rubber dam. So it's a modified kind of isolation. We removed the composite that we can see here. So the old failing composite, and we have sound enamel here. The idea here first, what do we need to do? We need to displace the gingival tissue because of the technique we're gonna use. And I wanna talk about the technique we used, something called the UVeneer. And the UVeneer, I'm gonna bring UVeneer again next week because not only directly in mouth, I also use, and I use a lot to do the wax up, doing diagnostic and my wax ups. So here, what I need to do, first of all, I need to displace the gingival tissue. Good news here, it is that it is a very healthy and a very strong gingival tissue. So it was easy to use. I used a cord that it is called UltraPack, also from Ultradent. UltraPack has a characteristic that I like very much. UltraPack is not packed. So there are some ways we can fabricate, that the industry fabricates the cords for us. One of them is by twisting some wires, some cords. When we twist, it is a more compact cord. When we braid, also it is more compact. But when we weave, like our grandmas, they usually do for us in a sock, they can be compressed. And this is a big difference in UltraPack. By being compressed, we can compress, we can put it inside of the sulcus. It is easy to put in the sulcus, and it stays in the sulcus easier as well. So it is easier to pack the cord into the sulcus. And we can see how the cord, it is compressed into the sulcus, and we can start doing a little bit, we can see a little ischemia here. This ischemia doesn't last long because there's no chemicals in this cord, so I'm not using any chemicals. So it's only a small ischemia that we're creating, not a chemical one. It is only mechanical, so it will last like seconds. But this is a good sign that the cord is doing its job. So it is really retracting and giving us 1 millimeter, 1.5 millimeter more of an operatory field. We have control, and we can be sure in this very healthy gingival tissue that also we are absorbing what? The gingival fluid. Why is this so important? Because we're gonna bond a restoration here. So we need control, not only from the saliva. Usually it's not the saliva who ruins our bonding step. Usually who ruins that? It is the cervical fluid. It's the fluid that comes from the gingival tissue. We need to control that as well, because saliva is big. We see saliva and we know we should fight saliva. Remember that problem, it is not the saliva, a hidden problem. It is definitely the cervical fluid, because this one, it is a very small amount and it is hard to perceive, okay? Awesome. By compressing by both sides, very gentle. And let me, and here we go. I'm compressing gently. I'm not using any chemical in this situation. I'm not using any chemical. Again, why? Healthy tissue, and it is strong tissue. I don't need to use this, any kind of chemical, any kind of hemostatic solution in this case. Gently compressing the material into the sulcus, and we get a very nice retraction of the gingival tissue. Awesome. Etching, we talked about that last time, so no big secrets here. But by etching, and this is what I want to show, and I was talking, maybe, I don't know if it was last week, maybe 2 weeks ago. This is what I want to show. It is this line here. After washing, after drying, theoretically, I'm doing everything on enamel. So enamel, it is what I have on buccal. But the thing is, this patient is not 18, 20, 25 years old anymore. She's almost 60 something years old. So what do we have already? Some retraction. Some retraction is more than natural after our 40s, 45 years. So you imagine in our 60s, in our 7th decade. So what do we see here? And I want to show here with my cursor the limit between enamel and the root and dentin. And why dentin? Because the cement is already been removed by being exposed. So the cement doesn't remain for long in mouth. It is removed quite easy in a matter of months after exposure. So what we have here is already exposed dentin, even a little bit more because we made a little retraction with the cord. So this is the thing. We need to take care of that because I did the total edge of enamel, but a little hidden band of dentin, and that dentin must be moist because I already removed smear layer. I already removed hydroxyapatite, a very thin layer, 0.2 microns, but I removed that hydroxyapatite layer. So now I need to do what? I need to rehydrate this little band here so the collagen fibers that we demineralized, they can stand still again, they can stand up again, and then I can infiltrate my primer, then my bonding agent, or my primer and my bonding agent if they're together in the same bottle. But again, this is topic from the other lecture, and this is why it is so important. And I remember I was lecturing in San Francisco, and one of the doctors, he asked me, hey, Rafael, you know why? One question, why class 5 restorations, usually they fail closer to the gingival line? One of the reasons is that one, because sometimes we're not etching enamel anymore. Several times we're etching dentin, and the needs of bonding for dentin and enamel, they're completely different, and we need to take care of that. It is a small world. Everyone here knows that dentistry is a small world. Another reason why they fail, because we're not taking control of the operatory field. So take control of the operatory field. Displace as much as you need and control the cervical blood also, but cervical fluid as well, okay? So having control of all that and doing the hydration of the little band of dentin. Now I'm doing the bonding as we talked last time. And this is how a good hybrid layer should look like. It should look, it's not moist, but it should look like it is moist. Okay, so this is a good looking hybrid layer. It seems moist even though it's completely dry. So only to remember 0.15 microns, very thin. It's like saran wrap. The saran wrap is the very thin PVC film that we use to storage food in our refrigerator. It is thin as that one, okay? The UVeneer, so what it was the technique that we chose to use here? We want to do something a little faster, and the UVeneer was created originally to be used as we're using here. So there's two ways. What is the idea of the UVeneer? It is a set of templates, and those templates, they follow all the proportions. So it is a 80% proportion of width compared to height, 80% more or less, and central, lateral, and canine, they follow the golden proportions. Also premolars, because that's what we get. Upper and lower from first premolar to second premolar. They follow all the let's say, aesthetic patterns on all the aesthetic proportions. So this is a good way, it's a good template for us to use in a faster way. Two ways we can use, and this is completely particularly, it's an opinion, and this is important. What I'm sharing right now is not the whole truth. It is what works best for me, because there's two ways we can use. One of the ways, we apply the composite into the tooth and then we press the template. This is one of the ways you can use. There's another one. You apply the composite into the template and then into the tooth. I prefer this second one. I prefer to first apply the composite into the template, making sure that there's no air bubbles trapped. And after I know there's no air, no bubble, little bubbles of air, I have to make sure. And if what happens if there is a little bubble? You remove before. So you reapply the composite onto the template. No air bubbles. There's no air trapping of any kind. Then I'm gonna press onto the tooth, okay? I prefer like that. I have friends that they prefer doing the opposite. They prefer applying the composite into the tooth and then pressing the template. I find it is easier. So it's a matter of personal choice. It is up to you what you feel better doing. One important tip I would like to share: when I'm doing both central incisors, I like to do both at the same time. I do both at the same time and I cure both at the same time. How do I do that? So those are little tips. And if you ask me, they are very important. What do? I use the handle as guidance, as parallel guidance. The handle gives you a very valuable information. Why is that? Because I have both handles like this, like two central incisors, left and right. If the handles are like this, I know it's completely wrong. If they are like this, I know it is also completely wrong. And if they are twisted, I also know they're completely wrong. So if I use the handles as an extension of the parallel lines, it's very easy to get what? Symmetry. It's very easy to get symmetry. When we're doing that freehand, anyone that did knows how hard it is to get good symmetry in central incisors. And central incisors, they are unforgiven. Lateral incisors, you can do some differences in shape, angles, and everything, not on central incisors. So this is one of the things I like a lot on the UVeneer, more than laterals and canines, is on central incisors, the symmetry that I get when I use the handles as parallel guides. Okay, again, if they are like this, or like this, we have to fix in all of those three axes. It's a three-dimensional universe that we live, and we should guide the handles in this environment as well, and they provide a very easy way for us to see if they are parallel and they're symmetrical as well. Okay, I do both. Let me come back here. I do both. I will separate them with a mylar strip. So I'm going to separate so I can have my gap, so I can use the floss, the dental floss. So I separate with the mylar strip. You can remove excesses and you can bind them again together. Cure both at the same time, okay? Then I'm gonna use the same technique for the laterals. But the thing is, for the laterals, I'm gonna place again centrals. Why is that? Because now I have more handles to guide me. The more handles I have, the easier it is. So now I have not only two, now I have 4 handles to guide me through the arch, three-dimensionally. So I use the handles a lot. Anyone that does dental implants know how important it is when you're using the parallel guides. So it's the same idea, but easier. To be honest, it's easier than when we do with dental implants. Canines, the same thing. So I'm using let's say the centrals, laterals, and then I'm gonna use canines. This is the before, this is the after, this is the immediately after. So let's take a closer look of what it is important here. One important thing, where the composite it is in contact with the surface of the template, there's no oxygen, which means that there's no oxygen inhibition layer, which means it's already polished. And this is something important. But some regions, they're not in contact. So some regions, like this one here and this one here, we need to polish by hand, okay? Some regions, and I wanna show that in a different perspective, here, so here, we need to do a proper finishing and we need to do proper polishing. So where we had the template in close contact, we don't need to do that. Or we can do a simple one. Next case, I want to talk about that. But here we don't. I want to bring this subject back again. So let's take a closer look on the case again. Remember the shine. Here, I don't need, so here is my cursor only to see. Here, it is already, let's say, polished because there's no oxygen inhibition layer. Interproximally is up to us, you know, to remove excesses and to the polishing. But the surface, it is already polished. This is one of the biggest advantages of the UVeneer. I want to bring the UVeneer back again, but first I want to show a more, I would say, realistic case when we're removing provisionals. When we're removing provisionals in larger oral rehabilitations, it might be a little harder because of what? Because this provisional, it is bonded, every tooth to the other. So it is impossible, actually, it's not it is hard, it is impossible to use the dental floss. Several times when we're removing the provisional, we see that the gingival tissue is a little inflamed. That's why it is important to use some substance, and the viscostat is a good example of that, some substance that denaturates some proteins in blood. So by denaturating those proteins that they were before soluble in water, they become what? Insoluble in water. And by doing that, we're creating, in a matter of seconds, we're creating an artificial coagulum, something that takes 5 minutes to happen naturally. We're gonna do in seconds, not minutes. We're gonna take us seconds to do that. So how do we create the coagulum again, Rafael? We do that by denaturating some proteins. Albumin is the protein that we do that with the viscous ferric sulfate solution. By denaturating a protein that naturally is hydrosoluble, it becomes hydroinsoluble, precipitates, we create this artificial coagulum. This is the first thing we need to do. Second thing we need to do, we need to create that coagulum inside of the capillaries. So that's why we need to rub, we need to scrub the solution into the capillaries. Okay, so the first case that I showed, I didn't have that necessity because it was a healthy gingival tissue. Next case I'm going to show, next two cases I'm going to show, that was not the case. Actually, the next one we're going to see that it was a very inflamed tissue. So that's what the viscostat does, creates coagulum very fast. Awesome. This is up to the material. What it is up to us to create this coagulum inside of the capillaries in the sulcus. So we need to scrub a little bit, not too much pressure, a little pressure, same pressure you would apply beneath your nail. So not too much pressure, but some pressure, same pressure that we feel in the sulcus, more or less the same thing that we feel under our nail. Same pressure you would use under your nail, you're gonna use into the sulcus, so you can create this coagulum, not outside, because if it is outside, it doesn't do any good for you. You need to create it inside of the capillaries, and this is what active hemostasis is, okay? Very well, there's also another way we can do that, and probably most of us, we learned that in dental school. It's a more gentle solution, and this is it's aluminum chloride. Aluminum chloride, there's a different kind of action, and it is written here. We can see the collagen fibers around the endothelium. We're gonna swell, in that sense, we're gonna swell these collagen fibers, and these collagen fibers will constrict the endothelium. So it's different. We're not creating a coagulum, we're squeezing the capillaries. So let's say it's a little weaker mode, but on the good hand, it is easier to wash than the ferric sulfate. Ferric sulfate is for bleedings that they're a little bit more challenging, like this case here. This is also a very nice case. And this patient, that was the last biggest case I did before the pandemic. So this case is from, I was looking at the pictures, it's from February. little, like 3 weeks before coronavirus struck in Brazil. And I remember because this patient, she lives like 120 kilometers from us and takes, because of São Paulo's traffic, takes more than 2 hours driving. She came driving 2 hours, 30 minutes into the appointment. I take a look at this kind of inflammation. It's a very sensitive tissue. So it's a very, this patient is very sensitive for inflammation, the gingival tissue. The gingival tissue is very, very, very sensitive. And it was really inflamed. So she took her 2 hours to drive to the office. In 30 minutes, I removed the provisional to do direct restorations in a very big context of oral rehabilitation here. Took me 30 minutes to tell her after 2 hours driving that there was nothing I could do, that I needed her to improve oral hygiene, and after 2 weeks she should come back. And she looked at me and said, like, really? I drove 2 hours, I'm gonna drive 2 hours back? So in 30 minutes you tell me that there's nothing you can do? Ideally, yeah, ideally that's what we should do. In the real world, I said, okay, I understand your problem and it makes complete sense. I cannot promise you, but I'll try to stop this amount of bleeding because you have a very sensitive tissue and I need, but I'm not sure because it's very extensive. It is a very big surface and I don't know. And I need not a little bit, I need total control because I'm gonna do 6 anterior direct veneers. And this is the secret. I'm sorry. By rubbing the material into the sulcus, I need to rub. I'm gonna create this coagulum. A lot of this coagulum is gonna be created outside. But I want that, and we can see here, this is the coagulum being created outside. This is coagulum here as well. You can see in my arrow being created outside, but I want to create them inside of the sulcus. And this is the before, this is after. It took me 10 minutes to control this amount of bleeding. It took me 1.2 milliliters. It's not much, it's 1 little syringe, so it's not a lot of material. It's one of the smallest syringes, but you need to keep on doing. You need to keep on doing because some regions you can create a coagulum and it stops right away. Some other regions, there's a lot and lots of capillaries. And remember, where there's inflammation, there is also formation of new capillaries. Those newly formed capillaries, usually they are defective, so they're destroyed by nothing. They're very fragile and they bleed again. So that's why some regions you win very fast, some regions you don't. Okay, so it took me 10 minutes. And everything that it is black, actually what it is, coagulum, artificial coagulum that I formed with the help of the viscostat with the ferric sulfate solution. Okay, it's artificial coagulum inside of the capillaries. Okay, in an anterior view, now I have control. Now I can place my rubber dam, and now I can do let's say the hybrid layer and the composite layering, because this takes time and we need to control not only bleeding, sulcular fluid as well. Okay, another case we can see here. So here, same situation. I removed provision, but different patient. So there is less inflammation. This is more regular. Usually that's what we usually see in our everyday practice, not that amount. So not the majority of our patients, they have such a sensitive gingival tissue. So this is usually what we have, a little gingivitis. And what I'm doing here, same thing, expressing material, scrubbing and rubbing a little bit, creating artificial coagulum. Let's take this in a closer look. I completely dried the operatory field. Now I can place my rubber dam, making sure that there is no blood anymore. There's no cervical fluid, no crevicular fluid anymore. So now I can apply my composite easily. And this is the case that I used another UVeneer, a newer UVeneer. So this patient, I still don't have the step-by-step, but I have the before and after. What is the UVeneer Extra? It's a new one. It's being newly released. If I'm not wrong, it was released this year. I'm not quite sure. I think it was this year, before the pandemics. And the UVeneer pretty much is the same idea of the UVeneer templates that you're gonna use to form your composite. But the UVeneer doesn't have what? The UVeneer Extra doesn't have the lower arch and also doesn't have the premolar. So it's only canine from canine, 4 different shapes and sizes. We have large and medium with the UVeneer Classical, and the UVeneer Extra, we have 4 different sizes: extra large, large, medium, and there's a more square tooth, which is a little smaller as well. And we don't have the lower arch. But what do we have? We have secondary anatomy, we have texture, and that's what I want to show. Same patient that I used the viscostat in the lower arch, now is the case that we're seeing. So it is part of a more comprehensive. So this patient is under treatment right now, and COVID really delayed a lot of the treatment. It's going to be like a 2-year treatment. It's going to be endo, it's going to be implants, it's going to be orthodontics. So it's going to be a lot of things, but we needed, first and foremost, we need to create a new DVO, a new vertical dimension, so VDO, sorry. And that's what I did with the UVeneer Extra. So in only one appointment, I removed the provisional and I created with the UVeneer Extra from lateral to lateral. Canines, those are provisional, PMMA, so metacrylatic resin. It is indirect, made out of mouth, it is not composite. From lateral to lateral incisor, upper incisors, I used the UVeneer Extra. So this is the before, this is after. Remember that canine back, we're talking about provisional. Okay, so it's a regular PMMA on the canines. Premolar back, we're talking about a bisacryl composite. Regular composite, it is lateral to lateral, upper and lower jaw. So all those 8 incisors for upper. For lower, I did with the help of the UVeneer Extra. UVeneer Extra only in the upper because there's no lower arch. So lower arch I did freehand, no big deal on that. I used on upper. And what I want to show it is this same concept. Use the handle as guidance. You use the handle as guidance. You do both at the same time. You go to the laterals. But this is the difference on the UVeneer, and this is immediately after, literally immediately after. Secondary anatomy, it is already there. So this is a difference on the UVeneer Extra. There's not only the primary anatomy, shape and proportions, there is also texture, and texture is secondary anatomy, and adds a little bit more. So I agree, the creator of the UVeneer system, she's called Dr. Sigal Jacobson. She's a great person. And she says something that I truly agree. She says that some countries, they depend too much on texture. And I agree with her. And I come from a country that maybe overestimates secondary anatomy. So Brazil overestimates, in my opinion, secondary anatomy. But on the other hand, it is hard to say that it is not a little bit more beautiful having this secondary anatomy. So if it is something that, and I know it takes me like 10 to 15 minutes to create these kind of things, this secondary, this texture in the tooth. If this is something that already comes with the UVeneer, for sure, is something that helps a lot in our everyday practice. So this is a very nice case that and again, remember, this is a provisional state. The patient, it is under treatment. But there's a question mark. And this is something I've been talking with the rest of the team, because we're a team of doctors who are taking care. There's the orthodontist, the oral rehabilitator, and there's an implantodontist, and there's everybody, endodontist. So we're talking with ourselves. This is provisional, but I'm not quite sure about this incisors. It might be a definitive as well. It could be definitive as well. So this is where the margins, they get a little blurred, where it is a provisional, if it is a provisional or not. So this is one of the good things about composites and having the help of good materials with us. So today I presented not actually two very challenging cases, the last two. First one was challenging because of time, but with the help of good technique and good materials, as always, we can manage good results. Okay, my friends, as I promised, it's gonna be a 30-minute lecture. Nobody said nothing on the chat. I don't even know if you guys are there. I know you guys are there, but it's always nice when you guys write something on the chat. I know, Alicia, you guys are there. But it's always good to have this kind of communication. Next week is one of my favorite cases. This one I did freehand. I made it a little bit harder than it should be, or it could be. This didn't need to be. I wanted a little bit more complicated. Didn't need it to be honest. I did it because I wanted, not because it needed to be. But it was a very challenging case because of he didn't have. This is an 18-year-old patient with only with the primary canines. It doesn't have, so it's a genesia. It doesn't have the secondary canines, the permanent canines. So it's a very challenging case. I don't know if because of color and translucency and opacity, I made it so, but because of function. And this is, I'm gonna be honest, this is one of my favorite cases. This is gonna be next week. Okay, so next week we're gonna have the 6th case discussion. Irina, thank you. And obrigada with the A at the end. Exactly, you're right. This is Portuguese. Next week we're gonna talk about this case. I think there's another one because I don't wanna talk only about that case. I wanna talk about anatomy, and next week is all about non-invasive technique. How can we change smile without even using the high-speed burr, without even using the turbine? So that's what we're gonna talk about, how possible it is. The patient doesn't even hear the sound of the turbine and we change their life. So this is what next week is gonna be about. I'm gonna talk about composites for sure, but in a not in a, let's say, less invasive. Next week is about non-invasive static rehabilitation. Julia, so Julia, thank you. Julia, what composites I prefer for static restorations? This is a very personal answer, Julia, and remember that it works very well for me. For me, works very well. I love the composites that you're seeing today. So all of the cases I shown today, it's a kind of new, it's not that new. I think it is already, I might be mistaken on that, 4, maybe 5 years old. It's called Mosaic. Mosaic is a composite that is available here in Europe. It was first available in US. It is available in Europe. Remember that I moved to Europe 2 months ago, but I was fortunate enough to have this composite in Brazil. I brought, one of my trips, I brought this composite to Brazil, even though it is not available in Brazil. It is not available for the South American market. But all the composites, the first, definitely the second, the third, and this one, all of them are Mosaic. I love Mosaic because of 2 things. One of them, it is handling of the composite. It is a composite that it is very good to spread on anteriors. Same composite is very good to scope on posterior. So let's say in posteriors, you want to create a sulcus. You turn back to get your lamp and you're going to cure, and you take, I don't know, maybe 5 seconds, and you do that 10 seconds, 15 seconds. What you sculpt is still there. Usually this kind of composite, it is hard to spread in very thin layers. This doesn't happen with mosaic. So it is very easy to spread and control the thickness. And this is what we're going to talk about next week. It is very easy to control the thickness. It's spreading the composite, but it is also very easy to sculpt the composite. This is one of the things. Second thing that I love, denting and enamel. Denting really looks like denting, and enamel really looks like enamel. As long, and this is very, very, very important, enamel looks like, mosaic's enamel looks like human enamel if we control the thickness. Another thing I'm going to talk about next week, if it is too thick, it doesn't look like human enamel. So we need to control that thickness. We need to spread. And remember, even though it's very easy to spread mosaic, I use the wetting resin. I don't remember when I talked about the wetting resin, probably on the first case discussion. Second was whitening. I think it was the first one that I talked about this material called composite wetting resin. So it's a liquid resin that helps me in spreading. And I'm going to bring this subject again for sure next week. So this is mosaic. It's by far the composite that I'm using more and more. Okay, thanks for your question, Julia. Thanks a lot. My friends, if there's any other question, please feel free. I'm here for that. If you don't want to make your question through the chat, feel free to write me in my email. Also, if you don't want to use that because you belong to a newer generation, feel free to write me on Instagram as well. And remember, any question that you have and you want to discuss, any case you have and you want to discuss, that's what we're going to do 3 weeks from now, because next one, we're going to talk about that non-invasive composite. The other one, we're going to talk about light curing, one of my favorite subjects of all time, but we're going to talk faster. Last one is going to be questions and cases that you guys are bringing me, okay? So counting on you guys. I haven't received anything I have received from Latin America, but not yet from you guys here in Europe. So I'm waiting on your participation, okay? My friends, once again, thank you so much. It's been a pleasure as usual. It's been our 5th time together. We have 3 more. Alicia, thank you so much as well. Julia, thank you so much. Petra, thank you. And Alexandra and Janka, sorry, I don't know how to spell. It's one of the things I need to do. It is to start speaking a little bit better languages other than the Latin-based languages, even though I'm speaking English right now and it is not a Latin-based language as well. Anna, thank you so much. Beautiful name. I love this name, Anna. One of my daughters is named after that as well. Cassia, thank you so much. Thank you as well. Glad you like it. My friends, if there's nothing anymore, see you guys next Wednesday. I know it's almost 9 o'clock. Take a good rest. Probably you guys are tired. Thank you so much. See you next week. See you next week as well, Alicia. Thank you. Bye-bye.